Go.
Good morning, everyone. I'm Manojna Beesetty. Today, my topic of presentation is vertigo. I've chosen this topic because since the start of this rotation, I have seen patients being presented with vertigo and finally being diagnosed with different medical conditions. So I thought I should be giving a presentation on how to narrow down to a diagnosis when a patient presents with vertigo. To start with, vertigo is a sensation of spinning or swaying of oneself, that is the internal vertigo, or of one's surroundings, the external vertigo. The pictures below they depict the two kinds of vertigo. The girl swaying shows how an internal vertigo feels like, and the other image of tree spinning around shows how an external vertigo feels like. Vertigo is caused by vestibular dysfunction due to an asymmetric vestibular input and may be spontaneous or triggered. So vertigo shouldn't be confused for dizziness or presyncope. Dizziness has no false sensation of motion, and presyncope is a sensation of losing consciousness. So we should be able to derive what exactly the symptom is from the history the patient provides us with. Next, going to the etiology, the causes of the vertigo are broadly divided into central and peripheral causes. For it to be central vertigo, the lesion or the dysfunction has to be in the central vestibular system, that is the cerebellum, the brainstem, or the vestibular nuclei. Some such conditions are vestibular schwannoma, cerebellar stroke. For it to be peripheral vertigo, the lesion or the dysfunction has to be in the inner ear, the vestibular cochlear nerve, or the semicircular canals. So some such conditions are vestibular neuritis, labyrinthitis, Meniere's disease, and benign positional paroxysmal vertigo, commonly known as BPPV. Usually, vertigo often presents with other clinical features, signs, and symptoms, which really help us in differentiating the causes of the vertigo. So here, this table helps us in differentiating between the central and peripheral causes of the vertigo. The cranial nerve features like dysphagia, dysarthria, diplopia are present in the central vertigo and typically absent in the peripheral causes of vertigo. The cerebellar features like dysmetria and ataxia are also present in the central vertigo and absent in peripheral vertigo. The nystagmus is definitely unidirectional and horizontal in the peripheral vertigo and could be horizontal, torsional, or vertical in the central vertigo. The picture here, it shows us three kinds of the nystagmus, the horizontal, the vertical, and the torsional ones. The hearing loss or tinnitus, these symptoms are usually common in the peripheral causes of vertigo and rare in the central causes of vertigo. Other focal neurological deficits like hemiplegia or facial weakness are usually present in the central causes of vertigo and typically absent in the peripheral causes of vertigo. So these are the main differentiating features which help us in differentiating whether the vertigo has a central cause or a peripheral cause. So patients presenting with vertigo are usually grouped into vestibular syndromes. The acute vestibular syndrome, it has an acute onset of continuous vertigo, gait instability, nystagmus, nausea, with or without hearing loss, and that could be worsened, but not triggered by movement. It usually lasts for about days to weeks. And the episodic vestibular syndrome, it has recurrent episodes of vertigo, often associated with gait instability and nausea, that typically last seconds to minutes. Symptoms may be triggered or spontaneous. The triggers could be the caffeine, nicotine, alcohol, or even positional changes. The chronic vestibular syndrome, it presents with continuous vestibular symptoms for about months to years. So how do we approach to a patient who presents with vertigo? Firstly, taking a focused history is vital. Determining the onset, triggers, or duration of vertigo. It helps in differentiating the different vertigo causes and also identifying associated features that also help in differentiating central and peripheral vertigos. As we have discussed earlier in the tabular form, the cranial features, cerebellar features, the kind of nystagmus, and also other focal neurological deficits. So all these features, they help us in differentiating the central and peripheral causes. We also have to identify any risk factors for ischemic stroke because brain ischemia is the main cause of central vertigo. So we should be evaluating for risk factors like male gender, advanced age, hypertension, diabetes, alcohol use, and also hyperlipidemia. Identifying features like episodic or acute onset could also help us in evaluating the underlying etiologies. Coming to the physical examination, performing orthostatic vital signs helps us in ruling out orthostatic presyncope. As I've mentioned earlier in the first slide, patients usually they get confused with the symptom of presyncope and vertigo. So we should be ruling out the orthostatic vital signs to rule out orthostatic presyncope. The evaluation of nystagmus, the examination of gait and other focal neurological deficits also help us in differentiating the central and peripheral causes. Coming to the targeted examination maneuvers. Firstly, let's go with the Hints examination. Hints examination is head impulse testing, nystagmus, and test of skew examination. The indication is symptomatic patients with acute vestibular syndrome. Hints examination is usually avoided in asymptomatic patients because it has a high likelihood of false negative result in asymptomatic patients. So we should be preferring to do the examination only in symptomatic patients with acute presentation. The objective is to screen for central causes of vertigo. The next step is once the Hints examination helps us and suggests that the cause is the central vertigo, we should begin urgent management and opt-in neuroimaging because central cause of vertigo are medical emergencies. And if a patient presents with an episodic vestibular syndrome, we should be considering a Dix-Hallpike maneuver to rule out benign paroxysmal positional vertigo. Going deep into the Hints examination, the first part is the head impulse test. It evaluates the vestibular ocular reflex. To start with the procedure, the patient should be asked to sit up straight on a table, then quickly rotate the head for about 10 degrees towards the side of the vertigo. A normal head impulse test is the patient would be able to maintain the central gaze fixed. And an abnormal head impulse test is inability to maintain the central gaze fixed, and we would be able to see a correction saccade of eye moving back to the center. And a normal head impulse test suggests a central cause of vertigo, and an abnormal head impulse test suggests a vertical cause of vertigo, peripheral cause of vertigo, sorry. And then coming to the nystagmus, in the peripheral pathology, the nystagmus is usually unidirectional and horizontal. And in central cause of vertigo, the nystagmus could be horizontal, vertical, or torsional, so it is bidirectional. Also, suppression of nystagmus when the gaze is fixed suggests a peripheral pathology. And nystagmus evoked by eye movement suggests a central pathology. Coming to the test of skew. Firstly, the patient should be asked to sit up straight and has his center gaze fixed. Then alternatively, we should be covering and uncovering his eyes. And an abnormal and positive test of skew is we could be able to see a vertical nystagmus or a misalignment. So that suggests a central cause of vertigo. The pictures here, they show the test of skew, how it is performed by covering the eye, and here the vestibular ocular reflex to evaluate head impulse test has been shown, and the 3 kinds of nystagmus have been shown here for better understanding. So how do we interpret Hints examination? Presence of any of the following suggests a central vertigo. Like we should be having at least one of these, either normal head impulse test or a central type of vertigo, central type of nystagmus, that is a bidirectional nystagmus, and a positive skew deviation. And presence of all of the following suggests peripheral cause of vertigo. That is, we should be having an abnormal head impulse test, a peripheral type of nystagmus, that is horizontal and unidirectional nystagmus, and a negative skew deviation test. For a patient who presents with episodic vertigo, so we should be going with the Dix-Hallpike maneuver. How do you perform this maneuver? First, the patient has to be asked to sit up straight, then has his central gaze fixed, then quickly turn his head 45 degrees and wait for about 30 seconds. Then lay the patient in the supine position so that the head extends downward for about 20 degrees and ask him to stay for about 30 seconds. A positive Dix-Hallpike maneuver is the patient should be feeling the sensation of vertigo or a nystagmus should be seen. That indicates a Dix-Hallpike maneuver positive, and it suggests a benign positional paroxysmal vertigo. The other diagnostics are neuroimaging. The indications for neuroimaging are clinical findings suggestive of central cause of vertigo, and also, as discussed earlier, the focal neurological deficits like hemiplegia or facial weakness and concurrent severe headache, and also the Hinds examination, as we have performed earlier. It also suggests, if it suggests a central vertigo, then neuroimaging has to be performed immediately. And also the risk factors of ischemic stroke and chronic vertigo are also the indications of neuroimaging. How are we supposed to do the MRI? The MRI could be done with or without the magnetic resonance angiogram. The findings, the abnormal findings, may be seen in patients with ischemic stroke, demyelination in conditions like multiple sclerosis or also tumors. And all these conditions are the central causes of vertigo, and the MRI absolutely shows normal findings in patients with peripheral causes of vertigo. The other diagnostics, audiogram, it is used to evaluate for sensory neural hearing loss, and it is seen in conditions like labyrinthitis, Meniere's disease, and vestibular schwannoma. The caloric testing, though, is not mandatory. The caloric testing with electronystagmography could be helpful in detecting unilateral peripheral vestibulopathy. So the pictures here, it shows us how the caloric testing with electronystagmography is done. The patient actually is asked to sit up straight, then fixes central gaze as usual, and the cold water, when injected into the ear, a normal caloric testing shows the nystagmus towards the opposite side, and when hot water is injected into the ear, the nystagmus should be towards the same side of the injection. That is a normal caloric testing, and if there's any abnormality in the caloric testing, it indicates a vestibular neuropathy. If a patient doesn't respond to cold water or a hot water injection, then we should consider a defect in the examination procedure, that is maybe using air instead of water to test the patient. And also, if there is aminoglycoside toxicity, it would generally distract the sensory cells and the neurons in the inner ear. So in such patients, the test would be unresponsive. So earlier we have discussed how we differentiate between the central and peripheral causes of vertigo. Now we are going to differentiate the multiple causes of peripheral vertigo. So firstly, we should go with the presentation of the symptoms. If the presentation is episodic, we should be considering Meniere's disease or BPPV. And if the presentation is continuous, we should be considering labyrinthitis and vestibular neuritis. Then, considering the hearing loss, we could differentiate Meniere's disease and BPPV. Meniere's disease has a hearing loss, and there is no hearing loss in BPPV. Meniere's disease also, it has a typical presentation of episodes lasting for about 20 minutes to 12 hours, and BPPV lasts not more than 2 minutes. So labyrinthitis and vestibular neuritis could also be differentiated based on hearing loss. There is hearing loss in labyrinthitis and no hearing loss in vestibular neuritis. As peripheral causes of vertigo, we could also differentiate it between different and multiple causes of central vertigo. So even here, to start with the presentation, if the presentation has an acute, falls under the acute vestibular syndrome, then we should be doing the MRI. It helps us show the brain ischemia, tumors, all the multiple sclerosis. The brain ischemia presents as stroke or TII, which typically lasts for about 5 to 20 minutes. And the tumors are seen, which could be resected or treated accordingly. The multiple sclerosis presents with periventricular demyelination, which when presented acutely could be treated with steroids or To maintain it, we could administer interferons. If the central vertigo has an episodic presentation, then it could be migrainous vertigo, that is, a vertigo presents with migraine symptoms. So the patient also presents with photophobia with or without aura of photopsia or distortion of vision. So treating migraine could help the patient. Coming to the management, the Meniere's disease and the vestibular neuritis, when present acutely, should be treated with vestibular suppressants. And they are the first generation antihistamines, meclizine, diphenhydramine, dimenhydrinate, the benzodiazepines, diazepam, lorazepam, and clonazepam. To go into management of Meniere's disease in a more specific way, the prevention therapy for recurrent episodes, it is low sodium diet, about 1500 to 2300 mg per day, and avoidance of triggers like caffeine, alcohol, nicotine, and stress. How do you maintain? The maintenance therapy is diuretics. They could be thiazidatics or acetazolamide. If the case is intractable, then we should go with the interventional therapy. And that could be by chemical ablation with aminoglycosides like gentamicin or surgical procedures like labyrinthectomy. Coming to the management of labyrinthitis, it is usually caused by acute otitis media with bacterial infection. So we should be administering IV antibiotics, tympanostomy with tympanostomy tube, and glucocorticoids. The management of BPPV is done with Epley manure. As shown in the image here, the patient first is asked to sit upright and has her central gaze fixed, then turn her head quickly for about 45 degrees towards the side of the vertigo, wait for 30 seconds, then lay the patient in the supine position with head extending for about 20 degrees down the examination table and wait for about 30 seconds. Then turn 90 degrees towards the opposite direction and wait for about 30 seconds. And again, turn 90 degrees facing the floor and wait for 30 seconds, and then ask the patient to sit upright. This is how we manage BPPV. And as said earlier, the central vertigo are medical emergencies and should be treated according to the diagnosis. The brain ischemia should be treated with aspirin, clopidogrel, and also in controlling blood pressure, diabetes. And additional studies and differential diagnosis. With the earlier examinations and targeted maneuvers, if we were unable to find out the cause of the vertigo, then we should be going with these additional studies. The studies are laboratory studies, CBC, basic metabolic panel, glucose, and vitamin B2 levels. Also the serum drug levels like anticonvulsants, the urine toxicology screen. We should also be doing electrocardiogram to evaluate for cardiogenic syncope or arrhythmia. The differential diagnosis could be pre-syncope or syncope, and the causes could be cardiac or non-cardiac. The cardiac syncope causes could be arrhythmia, so we should be doing the ECG to rule out that. And the non-cardiac syncope could be due to orthostatic hypertension, which we have also discussed that we should be measuring the orthostatic vitals earlier. Then the neurologic vertigo mimics are focal seizures, epilepsy, and sensory ataxia. Thank you for your time. I'm open for questions.